I am Professor Azizur Rahman, and in the last lecture of the series, we discussed very basic concepts about adrenal glands, its function, its anatomy. And today we are going to talk about one of the diseases called adrenal insufficiency. The definition, it may also be called hypoadrenalism. The problem may be in the adrenal gland itself, or problem may be in the pituitary sometimes. If the problem is in the adrenal gland itself, it would result in primary hypoadrenalism, and it is also called Addison disease. And this is after the name of scientist Thomas Addison, who first described this condition in detail. Now we will discuss some features. This disease is not actually very common, but as a postgraduate student and as undergraduate students, you need to know this condition very well. Whatever may destroy adrenal glands, particularly adrenal cortex. In the West, it is mostly autoimmune disease, and autoimmune disease may be very selective. It may destroy just the cortex, preserving the adrenal medulla. But sometimes other infections like tuberculosis, HIV infection, metastasis, or haemorrhage and others may destroy adrenal gland completely. Now we know that adrenal gland has got a lot of reserve. Only when 90% of the adrenal tissue is destroyed in both the glands, only then there is symptomatology. So it is possible that patient has hypoadrenalism and still may not have symptoms. Only during stress, when patient needs more corticosteroids, maybe only during stress phase patient manifests. Otherwise, only if there is 90% or more destruction of adrenal tissue, one would have symptoms. And secondary hypoadrenalism is not called Addison disease. Secondary hypoadrenalism is actually part of hypopituitarism. Usually, it would not be very selective corticosteroid deficiency. It would be part of a very complex syndrome where there is deficiency of other hormones also when there is some problem with the pituitary gland. Now, this is a very important condition. This would cause hypoadrenalism or Addisonian crisis, not exactly Addison disease. Somebody is on corticosteroid, maybe for some good reason. Patient has some autoimmune disease like SLE, or patient is taking for steroids for asthma or some other good reason. And a patient suddenly stops taking it. There could be multiple reasons why one would stop the steroid suddenly. So once if patient has been taking steroids for a long time in a supraphysiological dose, it is possible that his hypophyseal adrenal axis was suppressed, and once steroids are taken off, patient adrenal do not start producing corticosteroids, so there is deficiency of corticosteroids. Another similar condition is during the stresses, somebody is on maintenance dose of corticosteroids, and there is a stress situation, patient encounters an accident or patient undergoes an operation, and there is need for increasing the dose of corticosteroid. If somebody does not increase the dose, then there may be relative deficiency of corticosteroid, and that may also result in relative hypoadrenalism and sometimes in adrenal crisis. So pathophysiology, like many other hormonal diseases, first of all, there has to be some reason for the damage. And as I said, it may be autoimmune disease, or it may be tuberculosis, it may be metastasis, it may be hemorrhage, it may be trauma. Or sometimes it is just not known. We don't know why the adrenal gland is damaged. So first, there has to be some physical damage to both the adrenal glands. In my first lecture, I mentioned that both glands, although structurally two different organs, but they function as one. So if there is collective 90% or more damage to the adrenal cortex, only then there will be symptoms or signs. Irrespective of the cause of damage, there has to be 90% or more damage. Now that would obviously result in deficiency of mineralocorticoids, which is the main hormone for sodium and water regulation, and glucocorticoid, which is main hormone responsible for glucose, amino acid metabolism, and immune mechanism regulation. So deficiency of mineralocorticoid and glucocorticoid, both the hormones come from the adrenal cortex. If there is deficiency of these two, that would result in classical Addison disease. Androgens and catecholamine may also be deficient, but androgens, as I said, in men, since there is another source of androgen like testes, so there would be probably no effect of androgen deficiency in men. In women also there may be very subtle manifestation. Catecholamines, again, in autoimmune Addison disease, then medulla may be spared. Even if there is destruction of total adrenal gland by tuberculosis or by hemorrhage, catecholamine may not manifest in clinical form because of another source of catecholamine in the body, or it may contribute to postural hypotension, which is a characteristic symptom of Addison disease. Now, once there is 90% or more damaged deficiency of mineralocorticoid and glucocorticoid, this will result in clinical and laboratory abnormalities. This is usually a very, very slow process. So onset of Addison disease is usually very gradual. It is extremely hard to pinpoint the exact origin when patient has started having the condition. So it will be very subtle, very gradual, and many times these patients are initially treated as psychosomatic problem or general weakness or some other condition. The diagnosis of Addison disease is not very easy clinically. And clinical features, these photos, they show some of the clinical features, but I'm going to just describe them one by one. First of all, there would be weakness and lethargy. Now, this weakness and lethargy, they are general symptoms, common symptom. Many people, they have weakness and lethargy for very various reasons. Sometimes we cannot even identify the reason. It may be psychological also, or there may be nutritional deficiency. But one of the causes of weakness, and especially this lethargy, and especially if it is chronic, could be Addison disease. Now, pigmentation is very characteristic. Now, please remember, in our country, we have normally pigmented skin. So I think it will be very important to ask about the pigmentation. And the right question is if there has been any significant change in the pigment level. Now, many people would have increased pigment from the birth, but if there has been some significant increase in the pigment of the skin and many other areas, then that would be significant. Now, where you could find pigmentation? Anywhere actually. On the skin, in the flexor surfaces, on the palms, and on these the lines, and the mucosae, the lips, and the gums. And if you examine the cheeks, you will find some pigmentation there. And if somebody has some scar, especially if that scar developed after the onset of Addison disease, that would be pigmented. And those parts of the body which are normally pigmented, like areola, that might be darkened. So I think you need to ask the patient if that has happened, and that would contribute to the diagnosis of Addison disease. Hair loss, especially in women, and because axillary hair and pubic hair are androgen dependent. Now, if somebody has Addison disease, because of chronic androgen deficiency, there is possibility of hair loss in these areas. And then hypotension. Again, hypotension may be common in otherwise normal healthy people, but especially if there has been recent change in blood pressure without any medication for blood pressure, and especially if there is orthostatic hypertension. That means you check the blood pressure in the sitting position, then you ask the patient to stand up for a few minutes and to check it again. If there is significant drop in blood pressure, that would suggest that there is orthostatic hypotension, and one of the factors is Addison disease, because in Addison disease there is hyponatremia, there is contraction of extracellular fluid compartment, so that may cause hypotension, especially when patient stands up. Of course, you have to consider the fact that patient may be taking some blood pressure medicine. If that is the case, you first, I think, consider that possibility before you jump to the diagnosis of Addison disease. There may be weight loss, again non-specific, and inability to fight stress. This is again a relatively non-specific. So you, I think, must have figured out from these symptoms, none of these symptoms is very specific. So you need to have a very high index of suspicion. Somebody presenting with vague symptom, weight loss, pigmentation, and lethargy, you need to suspect Addison disease. Now, how do we investigate? There are two types of tests. One are specific related to hormones. When the suspicion is fairly strong, then we need to straight go for the hormonal test. Now, I have listed them. First of all, of course, serum cortisol. Now, serum cortisol I have listed first of all, not because it is the most important, but just logically, Addison disease means that there is deficiency of cortisol. So we would consider serum cortisol first, and it is expected to be low. But in some cases, in fact, in many cases, serum cortisol may be within the normal range, because we are testing in a normal in a patient who is not going through stress. When there is only relative deficiency of cortisone, there may be cortisone may be in the normal range. But in a classical case, or at least as per the pathophysiology is concerned, you would expect cortisol to be low. It should certainly not be high, but it should be low or low normal range. Then ACTH, we all know that cortisol has very strong inhibitory effect on the pituitary, and ACTH is expected to be high because when there is deficiency of glucocorticoid, that inhibitory effect on ACTH will be reduced and ACTH will be produced in high quantity as an attempt to increase cortisol production. In fact, the pigmentation of Addison disease is caused by ACTH, not by the deficiency of cortisol. That is why this pigmentation is only seen in primary hypoadrenalism, not in secondary hypoadrenalism. So when there is destruction of adrenal gland, there is reduction in cortisol, and that would result in compensatory increase of ACTH. So ACTH is expected to be high. Typically, we order these two tests together, and since cortisol has a diurnal pattern, so I think these tests should be done in a specific time. Best time is morning, and in the fasting state, I think about 8:30, patients should be asked to go to the laboratory and have these two tests. I suggest you should never have this cortisol alone or ACTH alone. It is best to have a combination, because you can build up your differential diagnosis very easily if you have a combination of these two. And the test must also be done from a good laboratory, because these are not routine tests, and only a good laboratory with high volume would be able to do this test correctly. Then aldosterone is not normally tested, at least that's not my practice. So, but if you do aldosterone level, it should also be low. Then 24-hour urinary ketosteroid. Now this may be little cumbersome because collecting urine for 24 hours may not be easy, but this may be very useful test, because this would give you the 24-hour average. You know, these hormones are produced in the form of pulses. So it is possible that if you do the test at the peak of pulse, then low cortisol may be missed. So this one gives you 24-hour value. So if this is low, this would be very helpful because it is 24-hour average, but it's a cumbersome test. Patient will be required to collect 24-hour urine. That may not be easy. So we usually skip this one also. The most sensitive test, the test which is likely to pick up Addison disease before these tests go abnormal, is ACTH stimulation test, because this would is like challenging the adrenal gland and asking it to produce more and more cortisol. If despite ACTH stimulation, adrenal glands are unable to produce cortisol, that would be an early sign of adrenal insufficiency. So this is the best test. We do not do it because we do not have ACTH in our country, but actually if you have ACTH available, you just have to do this test. You give ACTH and you do baseline cortisol, and you have another estimation like 30 minutes and 60 minutes. And if there has not been significant increase in cortisol after ACTH stimulation, that means adrenal cortex is not in a position to respond to ACTH stimulation. That of course means that adrenal are damaged. So this is listed at the end because this is not routinely done, but it is actually the most sensitive test if you want to pick up Addison disease early. Now other tests, like other routine tests, metabolic hyponatremia is easy to understand, as this cortisol, mineralocorticoid and glucocorticoid, they try to preserve sodium, and since in this case cortisol is reduced, so more and more sodium will be lost in the urine and there may be hyponatremia. Hyperkalemia, because again cortisol is actually helping to excrete potassium. If that is not happening, there is likely to be hyperkalemia. And some of these patients develop metabolic acidosis. And metabolic acidosis in these patients is not very frank like you expect in diabetic ketoacidosis or renal failure. It's a very subtle metabolic acidosis, but the picture would be like pH would be slightly acidic and bicarb will also be low. So in the proper context, in the context of clinical features and hyponatremia and hyperkalemia, metabolic acidosis will be considered a feature of Addison disease. Hypercalcemia is also sometimes seen, but of course there are other important causes of hypercalcemia. Everything is secondary to glucocorticoid deficiency, and everything may not be treated separately. So once we find the underlying disease and we start treating it, everything else gets reversed on its own. Hypoglycemia, because glucocorticoids, they have effect opposite of insulin. So the effect of insulin, when not opposed by glucocorticoid, there is a possibility of hypoglycemia. And even in those patients who are not taking any hypoglycemic agents, just normal healthy people otherwise, when they have not eaten for a long time, that is the time when glucocorticoid actually help to maintain our glucose level. In the absence of glucocorticoid, there is a possibility of hypoglycemia. Then elevated urea and creatinine, very minimal elevation of urea and creatinine because of volume contraction. Kidneys are generally not affected in Addison disease unless there is a separate cause, but slight increase in urea and creatinine is part of Addison disease. Lymphocytosis and eosinophilia, we know that adrenals, they regulate our immune system, and lymphocytes and eosinophilia, lymphocytosis and eosinophilia may also be seen in some cases, but these are not diagnosed. So like in any endocrine disorder, we have hormonal tests, but we also like to do imaging. We have three types of imaging tests, like we have ultrasonography, and we have CT scan, we have MRI. Ultrasonography is very useful because it is bedside test. It is very economical, no big cost and no side effects, but it has got limited sensitivity when you have to see adrenal glands, because adrenal gland is a small gland. But of course, if adrenal glands are enlarged, you can pick up. And CT and MRI would be done after the ultrasound if there is a suspicion. Now, what do you expect on ultrasound? We do not expect that the adrenal will be shrunken, because adrenal gland is so small already that I don't really think that we can see that they are shrunken. They may be expected to be normal in size or enlargement. In autoimmune disease, they would be probably normal, but if there is infiltration of adrenal gland by some malignant tissue or by hemorrhage, then you can expect enlargement. But I guess diagnosis is not based on these tests. Now the treatment, uh, normally the ideal treatment of any disease if we can address the etiology. Now in this patient, if somebody has autoimmune destruction of adrenal gland, it is usually not possible to address the autoimmune mechanism. And if it is due to tuberculosis, it is usually tuberculosis which has already healed, usually not active tuberculosis. So, and there is destruction. We have already learned that there has to be 90% or more destruction of adrenal gland before somebody develops this deficiency. So, even if you try to treat the etiology, patient will still need replacement therapy. So, etiology treatment is usually not possible. Patient need lifelong hormonal replacement, very important, and some other advices. I think first advice is that you may ask a patient to take plenty of salt and water because patient develops hyponatremia and dehydration. So you can start with salt and water supplementation. Uh, Later on, once patient is on glucocorticoid, then even then I believe patient should be instructed to take at least ample amount of salt and water. Then we have to replace glucocorticoid, and mostly mineralocorticoids are not needed, but you may need some cases. Why not? Although both are deficient, because glucocorticoids have multiple effects, including the effects of mineralocorticoid. So if we replace glucocorticoid, that and along with salt and water supplements, then patient may not need mineralocorticoid. And this has to be for life with periodic supplementation. Whenever patient undergoes some stress or undergoes some surgery or whatever reason, then we have to temporarily increase the dose of steroids. This needs to be explained to the patient. And androgens in women, although they are essential but usually not needed, but in some women they may be needed. If you want to replace androgen, it would be dehydroepiandrosterone. Catecholamines are not given. So all we need to do is to ask the patient to take plenty of water and salt and replace glucocorticoid in a physiological way, and I'll explain to you what I mean by physiological way. And in some cases, if despite the recommended dose of glucocorticoid, patient still is having hypotension, hyperkalemia, hyponatremia, then probably mineralocorticoid will also be needed. There's some general principle of replacement. Detailed counseling. Now, this is something which I think extremely important, that you explain to the patient that what is this Addison disease and why this patient needs replacement, and patient needs to be explained that he or she is getting just a replacement, not glucocorticoid in a very high dose. Because in our country, many times steroids are used without any rationale. So typical reflex of any doctor would be to ask the patient to stop steroid. So you need to explain to the patient that this is very important. For you, it is life-saving and you need to take it for life. Lifelong therapy, and try to reproduce diurnal pattern. That means we give slightly high dose in the morning and low dose in the afternoon to reproduce the normal physiological diurnal pattern. Hydrocortisone is perhaps the best, but we do not have uh, hydrocortisone available in our country or equivalent. Luckily, any steroids like prednisolone or dexamethasone or beclomethasone, whatever steroid available, you can prescribe in the equivalent dose. And bracelet or another identifier, that means it is best that patient should wear something indicating that he or she is on maintenance steroid dosage, so that if in case of trauma or accident, if the patient is taken to the emergency, the doctor can identify that person is on steroids already and he or she can be given supplement dose. So during stresses, it has to be increased. And keep injectable handy, because if patient develop Addisonian crisis, then injectable would be needed, because orals are slow to act and Addisonian crisis is a very serious condition. We need to inject cortisone. So this is the replacement therapy. Hydrocortisone, if available, 20 milligram tablet, one tablet morning and half tablet late afternoon. So that will be equivalent to 30 milligram of hydrocortisone. That is the approximate dose we need under the basal conditions. Of course, somebody is taking this dose would need to add some during stress. And some cases would also need slightly bigger dose, like 20 milligram twice a day, because the absorption and the metabolism of hydrocortisone may be different people. So 20 milligram twice a day or 20 milligram morning and 10 milligram evening. Alternatives are prednisolone. Prednisolone is available in our country. Prednisolone 5 milligram tablet, one in the morning, half in the afternoon, or dexamethasone is also available, 0.5 milligram tablet, one in the morning, half at evening. So whatever medicine you use, hydrocortisone or prednisolone or dexamethasone, tablet is equivalent to the tablet. So one tablet of whichever is available in the morning and half of that in the late afternoon to reproduce the physiological pattern. And we cannot monitor cortisone. Cortisol is not useful to monitor to see if the patient is taking enough dose, because these are, if patient is on prednisolone or dexamethasone, this is actually going to suppress endogenous cortisol, which was already low. So you cannot monitor cortisol to see if patient is taking adequate doses. We have to monitor ACTH to adjust the dosage. So if patient has been given the right dose, then there would be effect on the pituitary gland and ACTH should be normalized. Addisonian crisis is an extremely serious condition. Patient goes into serious shock, hypotension, and it should be dealt with like the principles of serious shock. Patient needs hospitalization. Patient needs intravenous corticosteroid. Patient needs IV fluids and other supportive therapy. And develop when steroids are discontinued abruptly or not increased during stress, and hospitalization, IV saline, and hydrocortisone may be needed. Prognosis of Addison disease, although we understand this disease fairly well, we know what is deficient, what needs to be replaced. Despite that, I think the prognosis of Addison disease at best is fair, because it is not actually possible to reproduce the exact physiological state even with replacement of corticosteroids, because these patients, they tend to develop problem despite replacement therapy. Their prognosis is not as normal as a person without Addison disease, even with treatment. With that, I'd like to thank you, and I'm looking forward to see you in my next lecture, which will be on Cushing syndrome. Thank you very much.